Hello, everybody. It's good to be with you today and bring you a new GYN Garage. My name's Ed Pavlik, and I'm in Lexington, Kentucky.
And
My
I'm Frank
colleague
Lawton.
is Frank Lott.
Sorry, Ed. And I'm Frank Lawton in London, UK.
Okay, Frank.
Home of international or European soccer.
Right. Well, I was worried about when the Orange scored early, but I agree
Uh,
with the penalty equalizer at 10 minutes later by Kane, and then it was spectacular at the 90th minute when Ollie Watkins' goal came through really tight into the corner. I will say the Dutch played extremely well. The question of the day, though, is can England hold off a high-scoring Spain on Sunday? What do you think, Frank?
well, two things, and I think the whole of the match, all of the matches have been more interesting after the 90 minutes, where there's been real excitement. A lot of it may happen in lots of sports, but I think a lot of the teams, certainly in the beginnings of the rounds, didn't want to lose rather than wanted to win. And obviously, when you get through to the knockouts, they want to win. But some of the football has actually been a bit dull, except when it comes down to the last few minutes, and it's been extremely interesting. I predicted the England wins all through the tournament. I thought it was going to be 3-1 to England yesterday. It was 2-1. I don't think we will beat the Spanish, who are supreme footballers and a supreme team. I hope that's not a harbinger of doom, and I hope Harry Kane is not going to listen to this webcast at least until after the event.
Okay, well, I hope your hopes come true. Well, today we got another question to talk about, and we're going to consider this question as part of Gynec Garage, not football. But the question is, are more fallopian tube malignancies being diagnosed and why? We consider this through a paper that was in the Green Journal, Obstetrics and Gynecology. It's titled Diagnosis Shift in Site of Origin of Tubal Ovarian Carcinomas. This work's important because it considers the evolution of the diagnosis of tubal malignancies. Uh, Let me say this, that we have two things going on. We have the report of more uh, 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 tubal malignancies increasing with windows of time. And that's what I have before you right now. And the odds ratio has shown that basically there's almost an eightfold increase, at least a sevenfold to about 2020. And that is coupled in a summary of more that there's a greater odds ratio of small tumors being diagnosed as tubal, and also unilateral tumors. So that's the summary, of this whole paper. Survival for both tubal and ovarian tumors was reported to pretty much be the same. So what we have here is a paper published by some well-known individuals in California in gynecology, and they've presented some good data. So if I give you a look at what the data looks like, let's look at that first. The first thing I point out to you here is that the proportion of tubal malignancies is small, even over the different time spans that were looked at for the reporting percentage. And still, as recent as 2020, the lion's share of diagnoses are for ovarian malignancies. The other thing I point out too is that the concept of the tubal lesion being involved in the onset of ovarian cancer or tubal ovarian cancer probably was born in 2001 or the early 2000s. And the record keeping here started about 3 years later, which is probably accounting for the fact that the proportions are pretty small of diagnosis of ovarian malignancy. The other thing I'll point out that occurs in this paper is just sort of a recapitulation of what I've just said, is that there's an uptick that gets sort of faster at about 2010 of the reporting of tubal malignancies as opposed to ovarian malignancies. Now, one has to say what can account for this uptick and for the increase, and we'll get that as we finish up. But that's an open question. Now, the other thing that happens to occur in this paper is that it reports that smaller tumors are more likely to be diagnosed as tubal ovarian malignancies. And we need to say, are there reasons that might explain this? And we'll get to this also in our summary. Now, lastly, the overall picture for survival did not differ with regard to whether we're talking about tubal or ovarian, but there were some slight differences when different groups were broken down. The most noticeable were for Blacks as well as for stage 2 disease. Now, I think what's happening here is if we go back to our original groups, and that was that there were, 7 times more ovarian diagnoses than there were fallopian tube diagnoses, that probably we're dealing with a small number phenomenon here, even though we have risk ratios that do seem to have some meaning. So if we look at this whole thing, I have to really ask, what can account for this increase? And one explanation is that what we're really seeing is the increased examination of the fimbria, so that sometime in the early 2000s, hardly any times were surgical pathologists looking at the fimbria, sectioning it, and seeing what was there. And later, as we move on, more and more surgical pathologists would have bought into the fact that they were going to look at the fimbria, and if they did, then they probably would see an indication of either a precursor to malignancy or the malignancy itself. The other thing was that I point out that if you have disease in 2 places, both the ovary and the tubal area, the convention now is to declare it a tubal malignancy, even in the presence of the ovarian malignancy. And so that'll take precedence, and that'll also account for some of the reporting. And lastly, perhaps accounting for the increase, is that as we move forward in time, there's been more and more risk-reducing salpingo-oophorectomies that find occult early-stage disease. And that would account for the report that smaller lesions are more likely to be tubal malignancies. So, that's sort of the way I look at this and interpret this. Frank, you have anything to add?
Yes, I think it's interesting, isn't it, that this seems to be a phenomenon that is associated with the introduction or the first explanation of STIC, tubal intraepithelial carcinomas, in 2001, and then the diagnosis increases from something like 5% in the early 2000s to I think the data's nearly 26%. According to this paper in 2007. So there's a narrowing difference in survival between the 2 groups, and I wonder, in actual fact, if we're dealing with the same disease, that for some reason pathologists have determined that many, possibly even the majority of ovarian malignancies are tubal in origin, not ovarian. So they're putting them all together. And from a clinical point of view, it doesn't really matter whether the disease is a tubal origin or an ovarian origin. It's still going to undergo surgery, debulking surgery, and platinum-based chemotherapy, etc., etc. So what I'm saying about this paper is, how is it going to change the management of patients with an epithelial ovarian carcinoma? And I don't think it is, to be honest. The histology might change, the prognosis doesn't appear to change. There now seems to be this very similar survival between the cases that have been diagnosed as a primary tubal cancer as opposed to a primary ovarian cancer. And I'm not, so we may be dealing with actually the same disease, or possibly the tubal variant is just an earlier, because it's smaller volume, an earlier peritoneal carcinomatosis, I think. I don't think anything is going to change from this paper. Pathologists I think, will get very interested and very excited about it. And I think pathologists have diagnosed tubal problems more commonly since it was first made aware in 2001, but I don't think it's going to change clinical management at all.
I think you're absolutely right. If anything, it'll lead to a stimulation of diagnostic improvements for pelvic disease that's not ovarian. This could be by liquid biopsy, or it could be by something of the order of an invasive type of look in high risk people. But that's just speculation. I think really for somebody who walks in today, there's not going to be a real difference. There's not going to be a difference in a pre-surgical chemotherapy. There's not going to be a difference in post-surgical chemotherapy.
I think from a point of view of prophylaxis, there may be a difference. That let's say a BRCA carrier, if indeed the link is there, obviously removal of the fallopian tubes laparoscopically from a premenopausal woman is far less a physiological problem to the woman than it is removal of the ovaries. And I think if there is a belief and an understanding that the majority of what we call epithelial ovarian cancers are actually tubal in origin, then from a point of view of surgical prophylaxis in premenopausal women, removal of the fallopian tubes after childbirth, it could possibly be something that this paper would benefit from the findings of this paper. You don't need to remove the ovaries, because the majority of women, at the moment, 26% of them appear to have their primary in the fallopian tube. That's not a difficult surgical procedure and has much less physiological and emotional problems than removal of the ovaries in a premenopausal woman. So I think that bit might be important. But I think from the point of view of the natural history of epithelial ovarian cancer, nothing much is going to change from this paper.
Well, absolutely. I think we're in agreement here. Hopefully you get some warm weather, and hopefully we'll get to cool off a little bit.
Well, it's sunny at the moment. Yeah, it's good.
So I'm off to
That's
the beach. Next time you see me, I may be totally red, but I'm taking the family to the beach, and looking forward to it this weekend.
All right, my friend.
Okay, you take care, Frank. We'll see you again.
And you, see you next month.
Okay, bye-bye.
Bye-bye now.